Welcome to the Dr. Lexi Show, where I take pregnancy topics and help to put them into simple terms to help you advocate for yourself and your pregnancy. I'm Dr. Lexi, a board-certified OBGYN and maternal fetal medicine specialist, which just means a high-risk pregnancy doctor. And today on the podcast, I have a very special guest, and I cannot wait to talk to her more and for you guys to learn so much from her. Lisa Miller.
Hey, thank you so much for having me. I'm excited to be here.
Thank you for being here. And you flew in all the way from where today?
From Vancouver, Washington.
Okay. Every time you say Vancouver, I always think you're in Canada.
BC. I wish.
Yeah.
I wish I could afford to live here. But the accent is 50 years in Chicago.
Chicago. Okay.
Back, take.
Got it. Okay. All right.
It's a nasal A, baby.
It's a nasal A. And I always like the listeners to kind of know a little bit of your background. And we can start with the letters behind your name, or we can start with, they go on forever. And, but like to kind of get a grasp on like your schooling, your kind of like where you are and who you are and what you do. And then we'll segue into why is that pertinent to what I do and all that jazz. But just give us some background on like who you are.
Okay. Well, I started as a labor and delivery nurse in 1979 in Chicago at Northwestern's Prentice Women's Hospital, which was a great place, still is, to have a baby. And I was a diploma grad. So I only went to 2 years of a hospital-based nursing school. This is before the big push for everybody to have a BSN. And while I was working there, I met a midwife, one of the few midwives at the time practicing in Chicago, Nancy Jo Reedy, and I saw what she did with patients, including supporting labor for high-risk patients. She worked with a maternal fetal medicine doctor. So she kind of became my mentor. And then I went and developed a maternal transport program up at, I think it's now called North Shore, at the time it was called Evanston Hospital, where we transported moms who were ill so that they could deliver their babies in a high-risk center. So we had, I think, 6 or 7 community hospitals that we would then transfer to Evanston Hospital, and it was usually 2 nurses who would go in an ambulance and go pick women up. So I developed that program.
How far were you into your nursing when you did that?
2 years.
Holy cow.
2 years. I had the funniest thing. They asked me to apply for night charge nurse after I'd only been there for 6 months. And I was like so honored. I went home. I told my mom. I realized now that nobody else wanted
the
that job. And they're like, oh, she'll malleable. She'll do it.
Yeah.
But anyway, so I did the transport program, and then I got into midwifery school at Medical University of South Carolina in Charleston. And this was, again, before all midwives had to have masters. So I got what's called a certificate in nurse midwifery, and that was in 1982, and literally drove home from South Carolina like nonstop through a storm to get home by Christmas at the end of 82 to be with my family, and started at Cook County Hospital as a nurse midwife shortly thereafter. And then I stayed a midwife, and instead of going back to school for a PhD or this type of thing, I had been contacted to do some expert witnessing in medical malpractice cases. And I met with these lawyers, and I thought, well, that's very interesting, and decided to go to law school instead of getting a PhD in nursing.
Did your friends think you were just cuckoo for Cocoa Puffs? Like, she's already this like rock star nurse and now a nurse midwife, and then it's like, I'm going to just keep going.
My friends did, A, think I was nuts, and then B, when I went to law school, you weren't supposed to work full-time if you were going to law school full-time.
Okay.
But, what they don't know won't hurt them, and I needed to make money. My father had died. I didn't have anybody floating my way.
Yeah.
And so I went to night school, but I worked at Cook County Hospital full-time. So I would work like a clinic Friday during the day, then work till 11 Friday night, and every weekend I worked night shift.
Oh my gosh.
And then I would go to law school Monday through Thursday. So for about 3.5 years, my friends didn't see me very much.
Sure.
I don't know. It was worth it. It was a great language to learn. It helped me be a better critical thinker. And I think it made me a better midwife.
Yeah.
Because I learned to evaluate evidence and not immediately, if I heard something, say, oh, that must be true.
Right.
It taught me to really think about it and do critical thinking.
So when you were applying for law school, when you ended up in that class, were there any other people in the class that were in the medical field as well?
There was one.
Yeah.
It's funny you should ask that because he was a pediatrician.
What?
And I can't remember why he was going, but we actually did a paper together that we ended up presenting in Toronto. It was basically about consent. If you recall, during that time, HIV was a big problem. And we did an article. They collect blood at birth for newborns to test for different types of abnormalities. Well, they had started testing
For HIV.
But what people don't understand is the HIV status of the newborn reflects the mother's status. The fetal status, it might clear because of the change of cells. It's a lot of like
Sure.
science that you don't have to understand. But what were they doing with the results?
Right.
They weren't telling anyone. They were just collecting the data.
What?
Yeah.
Wow.
So we actually
And they clearly weren't asking the patients for consent to test the baby. They just
no
were
consent.
automatically.
They were just
yeah.
doing it. And so we actually wrote a paper that compared this testing with out consent, but more importantly, without, to me, I shouldn't say more importantly, but also importantly, without notification and without follow-up.
Right.
We compared it to the Tuskegee syphilis studies. And we ended up presenting at some
Yeah.
forum in Toronto. And then I thought, oh my God, they're going to come after me. Because I guess it, then it changed.
Yeah.
When this got out
Yeah.
to the public, it changed. So that now you're informed of what your newborn is routinely tested for. And certainly when it comes to HIV and these issues,
Yeah.
I mean, to test somebody without their knowledge, collect that data, and never let anybody know that the mother,
Yeah.
because the newborn status really
Yeah.
reflects mother's status.
Well, and it wasn't recently, but it was, I want to say here in the Arizona area, maybe like 10, 15 years ago or less, they were testing all newborns for drug screens, mainly for marijuana. It wasn't consented for by the parents. It was just a overall screen that was performed. And there was something in the shampoo they were using on the newborns, and all these babies were popping positive for marijuana.
Oh my God.
And CPS was getting involved. So the parents didn't know that their neonate was screened, number one. And then number two, most of them had
Were
never
false-
smoked or used marijuana ever.
Right, it was all false positives.
Correct. From a shampoo. Isn't that weird?
It is weird, but I have found over the years, I'm going to be 66 in July, and I'm going to tell you this. I really believe in the world of healthcare, and especially in obstetrics, the truth is often stranger than fiction. Like that is a cliche that sticks.
Yeah, no, that's true. I agree with
So.
that. So really quickly, before I jump into some questions for you,
Okay.
the letters after your name, so that for people who may be in the medical field or like, hey, I kind of am interested in medicine, but I love law as well. So what are the degrees or something?
You want to know all of them?
I do, because
Okay,
I really
so-
do. Plus, I want to be able to write them appropriately.
I don't use all of them. I
Okay.
use CNM JD,
Okay.
which is Certified Nurse Midwife and Juris Doctorate. So all the letters, if I really did all of them, would be RN for Registered Nurse, BSN for Bachelor of Science in Nursing, CNM, Certified Nurse Midwife, JD for Juris Doctorate, the law degree. So the first three are all nursing. Juris Doctorate is a law degree. And then I'm also RNC certified in EFM. So that's another credential, but I teach
Okay.
fetal monitoring for a living,
Okay.
so I don't list that one.
Okay, and that's a great segue because we're going to talk so much today about fetal monitoring, and I'm so excited for everybody to hear about it. So that takes us straight into part of this about making sure you're up to date on what's going on in your field, right?
Yes.
And I know, as an obstetrician and gynecologist, part of that is being an obstetrician, right? And so that's
Yes.
dealing with babies, monitoring babies, delivering babies.
Right.
So hospitals may say to people, oh, you have to do all of these modules that the hospital requires, right? And the biggest thing I think people during their pregnancy are partially concerned about is the delivery. How's my baby going to be monitored? Who's going to monitor my baby? Who's delivering my baby? That's a huge, like there's a lot of angst and questions and nervousness surrounding that. And how do we get to the point to know that the providers are doing the right thing?
Well, I think that comes at the first visit. So one of the things that we did in my practice, my midwifery practice, is we had a first visit that was 45 minutes in length. And we actually, prior to that, and that included your physical, everything else, but we offered a free, no charge, 30-minute appointment to interview us for the practice. Now, we only had so many of those available per week, so because, we had to see patients.
Sure.
But at that initial screen, which, again, we didn't charge any money for, you could come and visit, we talked about how the practice worked, we answered questions, and we encouraged people to bring their questions. So I think that's a great way for women and birthing people to figure out whether there's a good fit in the practice. One of the things that I always said to the families that would come see me is, I am not here for when everything goes perfectly. When your birth plan, everything is unfolding as it should, there are no problems. I am here for if there is a complication, if there is a problem, you can trust that I will do the safest thing to ensure that you and your baby are protected and are taken care of. And that, I think, is the most important thing. So, in short, if you were coming to me for the perfect birth, I don't want you to come to me. No, because nobody can guarantee the perfect birth.
No.
Now, our C-section rate was low. I brought water birth to Northwestern. I was a big proponent of non-intervention. But on the other hand, we had people who had risk factors. We had people who needed intervention. So what I wanted to make sure people understood is that I am here as a safety net. And if your goal is I want the perfect birth experience versus I want to go home, I want the safest experience I can have, hopefully going home without any problems and a baby not having to go to the intensive care nursery, then this is the practice for you.
Then when you mentioned the monitoring, that's a big hot topic for the last 10 to 20 years, honestly.
Yeah.
And the monitoring, I want people to be able to kind of understand what you said, and that there are people that are appropriate for not having to or not being recommended to have continuous monitoring. And
Correct.
there are people that should get continuous monitoring due to certain risk factors they may have.
Yes.
So if there's a patient trying to navigate, like, I don't know if I'm considered the right person for it or not, should they be able to ask their provider directly? Is it the hospital the day they go in? Like, I don't know.
Yeah,
like,
it's definitely not the hospital that they go in. These are conversations you want to have at their first visit. So let's say I'm seeing an OB-GYN. Okay, so I'm not seeing a midwife. I'm seeing an OB-GYN, and I'm doing the interview or maybe having my first visit. What are your thoughts on intermittent auscultation versus continuous fetal monitoring? So intermittent auscultation is where we just listen to the baby's heartbeat with either a special type of stethoscope or a little what's called a pocket Doppler, which is an electronic means, but we're just listening. We're not getting a printout. You're not strapped to any monitors, anything like that. And then we're just palpating. We call it touching to feel contractions.
And this is during labor, correct?
During labor.
Yeah.
So this is it's called intermittent auscultation and palpation, completely appropriate way for women who do not have risk factors to be monitored during labor.
And supported by ACOG.
Supported by ACOG,
Yes.
supported by all our professional
Yes.
organizations. And that's what I grew up with. In 1979, we only had 3 monitors for 18 labor rooms. So the tipping point in electronic fetal monitoring, the machine where you have belts and you're attached to it, that came around 1982. By that point, everybody was being monitored. And the problem is, and I think this is a problem in so many things, that people will hear things on the internet or they read something on a site, and it's 2 extremes. It's like fetal monitoring is the worst thing, and that's what's causing all the problems, and we should get rid of it. Or neither is true.
It's a continuum.
Both both modalities are appropriate for different types of patients. In addition, even with continuous fetal monitoring, what you want to find out way ahead of time is what types of monitors you have. there's now what's called patch or telemetry. So these are types of monitoring that do not restrict mobility, where you can be up, moving around, or sitting on a birthing ball, or doing whatever you want, and still getting a continuous tracing if that's what we need. So everybody should be familiar, as far as clinicians, with all these types of monitoring. In the best of all worlds, these would be available to all women and birthing people.
Yeah.
With shared decision making, which there's a lot of what I think is lip service to that right now. Like, it's a big buzzword, but are we really sitting down and having the conversation?
Right. Well, because that's the next question I was going to say, is that if someone comes in hot, right, and they're like, I only want intermittent monitoring, I do not want continuous.
You mean intermittent auscultation?
Sorry, intermittent auscultation.
I'm
Thank
just
you.
going to say, because there is a group where you'll sometimes be using auscultation and maybe then getting a monitor strip should something happen.
Yes. And so if it's intermittent auscultation that someone desires, just like you said, I feel like there has to be that, well, I don't feel like, there has to be that conversation to consent them for it, to understand, are you an appropriate candidate? Do we agree that that's safe for you and baby?
Right.
Number one. And then if you understand you still have risks for XYZ and you still want to do that, you're consenting for it. Because if a fetal demise were to occur for whatever reason, I don't ever want a patient to come back and say, no one told me that was a possibility.
Right. And it is a possibility. I mean, here's the thing. One of the things that electronic fetal monitoring did get rid of through its use is intrapartum stillbirth. So when I started as a nurse, you'd be listening with your special stethoscope called a fetoscope, or there's another one called a Pinard. We didn't have pocket Dopplers yet. That was very high tech.
Not to interrupt. Okay, Pinard, when I hear that, those are breech extraction moves. So is that the same guy?
No, I don't. It might be the same doc.
Oh.
It might be, because it's old, but a Pinard is like a tube, and you can Google it or look for a picture, or maybe you could put a picture in a link or something.
Okay.
But that's very old school.
Okay.
A fetoscope is probably more common, and that's what I use. But I'm familiar with the Pinard. But anyway, those things were done, and you'd be listening, and then you come back and listen and not hear anything. So, people always want to vilify things. We need to be a little less inflammatory about issues and think realistically.
Sure.
Yes, there are problems with fetal monitoring, but in my opinion, it's the problem with how it's being used, or shall I say misused, versus the technology itself.
Yeah.
So anything can be misused.
Yeah. And exactly like you said, with so much in social media right now, people want to go one way or the other and just staunchly stick behind it and then be angry at the other end. Right. And a lot of providers, at least when I was in the hospitals more, they would get frustrated with the patient that refused, and they would, say declined or refused continuous electronic fetal monitoring, because as the provider, their job is to try to get a healthy delivery. And if there are times where we can't see that fetus on the monitor, our mind is always trying to go to worst case scenario so that we're prepared for worst case scenario. Not that we want the worst case scenario, but worst case scenarios, there's not a heart rate when we put the monitor back on, or any monitor back on. Right. And it always would shock providers, how could someone choose that? But my thought is, was there the right discussion? Why is it that someone wouldn't want continuous monitoring? Are the belts confining? Do they bother them? Have they heard scary stories? Are they, sometimes if you just ask a little more, you may understand it and figure it out a little bit. But in all honesty, patient autonomy is number one. I feel like it really is. You've got to give people the choice. And I am not a fan that patients are so often on social media putting, my doctor told me I had to do this.
Well, and I'm against that as well.
Yeah.
But again, it starts early on.
Yes.
These are not discussions that can be had when you present in labor. That's unfair. And it's particularly unfair to labor and delivery nurses, who shouldn't be the arbiters of what type of monitoring you're going to have, or whether or not you have an induction. That should all be discussed before you even start labor between you and your provider. And if you see someone at the first visit who's not willing to have these discussions, to discuss birth plans, to talk about fetal monitoring, to share their experiences and whether or not Are you certified in EFM? When's the last time you got to a fetal monitor course? What do you know about? Like, those are questions I would ask. And so we need to, I think, empower, and that's why I love your channel and what you're doing. We need to empower women and birthing people to, these are the questions you have a right to get answered. And if they don't want to answer these questions, get out.
Yeah.
Go somewhere else.
Yeah.
The problem is, these days, there are some places where you don't have anywhere else to go.
True.
Rural healthcare issues are becoming really limited for OB. There are maternity deserts. I'm sure you're familiar with that term.
Oh, yes. Yeah.
So when we talk about patient autonomy, what if this is the only practice that's available to me?
Right.
Or my insurance.
Yeah. That used to be a big frustration of mine, is thinking everyone needs this level of care. Because in my mind, they all should get the same. Everyone should be able to get this level of care. And then as I've been, covering clinics in various places, they don't have the opportunity to get a certain level of ultrasound, or it's just
not available.
It's just not available. Yeah.
Right.
It's frustrating.
Frustrating and very sad in a country that spends a huge amount of its
On healthcare.
growth national product on healthcare.
Yeah.
One of the wealthiest countries in the world, and yet our stats aren't that hot.
No, not the best. Not the best.
No.
I'm trying to think of other things too when we're talking about that delivery time, because I think it's so scary for people. I know that monitoring is one that's huge. The other two topics that come up a lot are inductions and then the use of Pitocin, whether you're being induced or you're being augmented or whatever. And, Pitocin is something that as someone who did OBGYN before I started doing maternal fetal medicine, we use it very frequently. I think it's a drug that we are comfortable with as obstetricians. And I think it's becoming a very scary drug for a lot of lay people in the general population. So can you talk a little bit about that?
Oxytocin is the hormone we naturally produce that triggers labor, and it does all these other things, the maternal-infant bonding and many other things. But what has happened is, just like EFM, electronic fetal monitoring, oxytocin is often misunderstood. It can definitely be misused. Believe me. I mean, one of the things I'm teaching clinicians is how to safely use it. But it inherently is not a dangerous drug. But you'll hear this online, okay, that it causes brain damage, that it causes autism, that it causes other things, none of which is true. It's what's called a high alert medication, which is a designation not given because a drug is dangerous. The designation actually says under high alert medications that these are drugs that, when used inappropriately or in error, have an increased risk of causing harm. So it's like anything else. Here is something that could be really helpful, and in many cases is absolutely needed, but you get people into these camps on social media vilifying it. And it's like anything else, it can, I feel like it can be used for good or used for evil. and you've got to understand how to use it for good.
Yeah.
So how you titrate it, when you decide to have an induction, these are also things that could be asked at a first visit. And maybe you and I should come up with, like, you probably already have it and I don't know about it, like a list of questions to ask at the first visit.
I have some, but you know
probably have
what?
Something like that.
I have one. It's 13 questions to ask your provider. However, none of them are questions for labor.
Well, then let's work on that.
Yeah, because I am more outpatient now.
Yeah, of
my
course.
brain is centered more around that, and that's just where I go with my pointers and stuff. And then as I've been building things, that is what people have been like, hey, don't forget about that. And I'm like, oh my gosh, that's such a good point, because I make the assumption that the OBs are totally talking to every patient about that. But I don't think they are.
No, and even the midwives aren't always.
Providers.
And sometimes they are, sometimes they aren't, and a lot depends on the practice. But I think having a list when you go in of these are the questions, and if you're getting pushback on any of the questions, to me that's a red flag. That's I welcome your questions. If you're coming to me, ask me whatever you want. And in fact, I wish we had more resources for dialogue about this, so that it was clear that if I'm coming in to your office and I'm the patient, me asking you these questions is as part of a partnership.
Yeah, it's welcomed
in healthcare, and it's welcomed by you,
Yeah.
and time is made for it. I think that's the other thing. Billable hours
Yeah.
are a big issue.
Big
a
time.
lot of places pay physicians and even midwives on something called RVUs, which is, I don't know what it stands for, revenue something units.
Yeah.
And it's basically, you have X amount of time for this visit. Well, what if somebody needs more time?
Yeah. This is a big reason why I don't work in the hospitals anymore, because there were so many limitations placed upon what I could do, but I didn't stick within those limitations. So I would spend more time, not get paid for it, which was not the point, but then get not in trouble, but, oh, it's not good that you're staying later. You're doing this extra work. Cut your notes shorter. Spend less time with patients.
Right.
No, gracias. I don't want to do
thank
that.
you.
And I really have a bit of a bleeding heart for people still in these hospital systems. They're being bought out by large companies and corporations. They're really getting worked to see more patients without any increased pay and with less time with the patients, which is hard. And the biggest part within that too is a lot of the questions that a patient would bring to them, they may not be able to answer, and I'll tell you why. Protocols. Because to make things more efficient, they click a box, or someone, when a patient gets admitted for a delivery, clicks a box and 20 things get checked off, right? Place Foley catheter as
standard
needed,
orders.
standard orders. So if you ask any physician, practicing physician, they will not know their Pitocin protocol, I bet. If you ask a resident, they might. They might.
If you're at an academic center.
If you're at an academic
But
center.
if you're in private practice and you don't know what your Pitocin protocol is, I think that's it. And you're doing deliveries.
Right.
Not I'm only seeing patients in the office, and a laborist or a hospitalist is going to be managing the labor and doing the delivery. If you don't know that, that's a problem.
I wish we could take a poll right now, like if people were watching live, and it would be like, okay, if you're an OBGYN, like physician, tell me this. And then if you checked with the nurse midwives and the nurses that are caring for the patients, they would know.
Well,
I think, but again, I'm biased.
more of them may know.
More of them.
But I guarantee you there's plenty that don't know.
And then they would probably think the
and
physician should know.
also know only one thing. Like a protocol is helpful, but if you don't know the underlying physiology upon which the protocol is based, you're not going to know when to what? Step outside the protocol.
Yeah.
No matter how well drafted a protocol or a guideline is, there's always going to be a clinical scenario where you should do something slightly different. That's critical clinical judgment.
Exactly.
And if you don't have that, because you don't have a kind of repository of core knowledge, it doesn't matter what the protocol says. There's going to be a problem somewhere along the line.
Yeah. And that's what I think. Protocols are great, but you need to be able to, like you said, deviate appropriately when something's not going right and understand the reasoning why you're giving this hypertensive medication instead of that one, versus the fact that you just gave it 3 times and it didn't work and now you're meant to go to this other one.
Or making a delivery decision. So if you understand that with certain very high BMI patients, it's going to take longer in a cesarean to get from the skin incision to get the baby out, you're not going to factor in that time when you're making a delivery decision for, do we need to go now or can we wait?
Yep.
So all of these things, critical thinking, I think, is the biggest thing that comes into play, even with well-drafted protocols,
Huge.
policies, and guidelines.
So I hope everybody got to learn a ton today. I know I did, as always, when I get to visit with Lisa. And if you have any questions, let us know. Leave questions below. We'll have tons of links below with resources for you, as always. And if there's anything you want to hear about in the future, let me know in the comments below. I hope you all have a great day. And as always, I'm Dr. Lexi, wishing you a happy and healthy pregnancy.